doing the ultrasound scan, you see I'm seeing cystic spaces which I really couldn't see well on trans-abdominal scan. But I do see flow inside, but I am not able to see where is the feeder vessel. Because flow inside a polyp could be anything. It could be endometrial hyperplasia, it could be endometrial cancer, it doesn't tell me it's a polyp. And this is because this feeder vessel was lying perpendicular to my ultrasound beam. So I'm not able to trace this on transvaginal scan because the uterus is mid-position. So when you have a mid-position uterus, you may not be able to assess the endometrium properly. So you should try, first of all, in every single patient, I do a very detailed evaluation of the endometrium on trans-abdominal scan because I know in trans-abdominal scan, the endometrium is perpendicular to my ultrasound beam and vessels typically are parallel. Then while doing the transvaginal scan, I usually move around my probe to see if I can flex, I can push and flex or retroflex or antiflex the uterus to make the endometrium move perpendicular to the ultrasound beam. But it's easily said and it's not always possible, therefore it's very important to do a TS prior to a TVS. Now, endometrial polyps are most often benign, fortunately. More than 95 to 96% of polyps are benign. And what are the features in a polyp that tell me this is likely to be benign? One is a smooth outline of the polyp. So even though this is a secretory endometrium, you can see an artery and a vein entering in. You see that the margins are pretty smooth, and here at this point you can see. So smooth outline, and sometimes BCI 3D can help you make the outline even more clear, but 99% you don't need it. You can see it very well on 2D. Single feeder vessel or a single pair of vessels supplying that polyp, and presence of cyst, tell me it is more likely to be benign. So this is a typical benign polyp. Here is an adenomyomatous polyp. Now adenomyomatous polyps are not that common, and I want to show you this because sometimes if you see a polyp like this, it's not nicely uniformly hyperechoic. They tend to have they have smooth muscle along with the endometrial tissue. So you get some amount of heterogeneity. They are more hypoechoic. You may see cystic spaces, you may see bright echos, you may see a little bit of shadowing. They are more fleshy, and instead of one vessel, you may sometimes see 2 or 3 vessels supplying an adenomyomatous polyp. Here was a polyp, you can see there are 3 vessels supplying it. And then you can have benign hyperplastic polyps. This was a large polyp. You can see there is cystic changes, there is cystic hyperplasia, there is a prominent feeder vessel. So that again is a benign polyp. And here you see you have multiple small polyps that you can see here. All of them had tiny feeder vessels inside. And when you see multiple tiny polyps, think of the possibility of hyperplasia. So this was again a patient with endometrium with multiple small polyps, like a polypoidal endometrium, but with no atypia. So this is the variety. Of course, this is the most common that we see. Moving on from benign to malignant polyps, how do I know a polyp is likely to be malignant? One is an irregular outline of the polyp, and second is multiple vessels in a focal area. So there are in one small area supplying the polyp, there are multiple vessels coming in. So this was focal endometrial cancer. You can see the irregular outline and multiple vessels in a focal area. This was another patient. Again, if you observe carefully, remember, fluid is our friend when we are evaluating the endometrium. So here you see, because of blood, I could see this very well. Again, there's little bit of fluid, and the moment I see fluid, I'm looking carefully, I can see that the margins of this polyp are irregular. And again, there are multiple vessels supplying this, so I know that this is again likely to be malignant. This is the specimen after surgery. You can see the polyp with an irregular surface, and that was a Mullerian adenosarcoma. So remember, anything with an irregular outline and multiple vessels in a focal area, think that polyp may be malignant. Now the last possibility is hyperplasia with atypia, which is also called as endometrial intraepithelial neoplasia. Again, I'm seeing a hyperechoic polyp, but what drew my attention was that there was this irregular outline, not like the regular polyps. You remember the ones we saw in the previous slides. So I looked at this, there were 1 or 2 vessels. It looked like there were more than 1 vessel entering this polyp that caused more concern. And of course, on 3D. So remember, 3D is a great add-on to 2D. Make your diagnosis on 2D and then to confirm that diagnosis, use 3D. So here you can see the irregular outline of that polyp, and this did turn out to be hyperplastic polyp with atypia. Moving on from endometrial polyps to endometrial hyperplasia. We know hyperplasia occurs because of unopposed estrogen action, and these patients have a thick endometrium, and what they complain of typically is menorrhagia with or without amenorrhea. So they have long period of no ovulation, long period of amenorrhea, and then excessive bleeding. What are the ultrasound features of patients with hyperplasia? They have a thickened endometrium. We know the cutoff is 5 and 15. 15 is a relative cutoff. The endometrium surprisingly can appear 3-layer, it can appear echogenic, it can appear heterogeneous, it can show tiny cystic spaces. All the above are possible. The endometrium is occasionally polypoidal. In fact, this was a polypoidal endometrium. You could see like multiple polyps, so you can get a polypoidal endometrium. The vascularity of the endometrium is generally increased, but look at the vascularity difference. There is multifocal, single, scattered vessels all crossing the endomyometrial junction. So the vessels are all seen crossing the endomyometrial junction and feeding the endometrium, which is actually the normal pattern in all patients, except in hyperplasia, these vessels and the Doppler flow is more, so they look brighter. So the flow into the endometrium is larger, but the pattern of flow is what is normal for the endometrium. Multiple vessels crossing the endomyometrial junction and running an almost parallel course within the endometrium. Can you see that? This is how you see an endometrial hyperplasia, and if you do 3D, with power Doppler or HD flow, you will see the same pattern. So there's not much difference between 2D and 3D. Same uniform pattern of vessels crossing the endometrium. Since hyperplasia is associated with hyperestrogenism, you should carefully look at the ovaries. One of the commonest causes is polycystic ovaries. It could be obesity or rarely a hormone-producing tumor like a granulosa cell tumor. Now let's look at one case with typical endometrial hyperplasia. You see a thickened endometrium 21 millimeter. You see tiny cystic spaces within. The endometrial volume, if you measure, is also increased. You see multiple vessels crossing the endomyometrial junction and running an almost parallel course. And can anybody tell me what is this? Anybody shout out and tell me what this is? This is not a feeder vessel for two reasons. It is not crossing the endomyometrial junction, and it is actually in the lumen. This patient is menstruating, so there is blood in the center, in the lumen of the endometrial cavity, and this is an artifact caused by blood flowing within the lumen of the endometrium. And if you apply pressure, you may see from red it may become blue because the blood may go reverse back into the endometrium. And this, of course, is on 3D glass body. So this is the video clip of a patient with endometrial hyperplasia, and you can see the multiple cystic spaces. You can sort of make out the midline. Here is an artifact produced by blood flowing in. You see those multiple vessels crossing the endomyometrial junction, and the appearance is the same on 3D. Another patient with endometrial hyperplasia. Here it was not so obvious like in the previous case. You didn't have those cystic spaces, and the endometrium looked very heterogeneous. So what I did, there were a few cystic spaces, but it looked extremely heterogeneous. So we did a saline infusion. When you put in saline, remember, you just have to put 1 to 3 cc. Don't put in too much saline, because if it's a case of endometrial cancer, you can potentially spread it to the peritoneum. You just require 1 to 3 cc and quickly take a 3D sweep. When you take a 3D sweep, the volume is left with you and you can work on it. So there's the infant feeding tube number size 7. I put in a very little amount of saline, and I immediately take a 3D sweep. You see my 3D probe is ready. You can see over here that the endometrium was polypoidal. Can you see that? But what is interesting is the margins are smooth. That tells me this is unlikely to be malignancy. So here was the patient. You can see this is how it appeared on with saline. This is how it appeared without saline. I thought it was polypoidal, but what is very nice is to see these nice regular margins both on 2D and on 3D. Now, one thing very important, a polypoidal endometrium can be physiological. You can see it in patients in secretory phase. So just because you see a polypoidal endometrium, it doesn't mean it is hyperplasia. It could be pathological or it could be physiological. So if you see it in women of the reproductive age group, please call her back in the early proliferative phase. And if it is still looking polypoidal, that requires investigation. Now this was a patient with complex hypoplasia with atypia. Another patient with polypoidal endometrium, 78-year-old lady. So I don't have to worry about it being physiological. At 78, you cannot have a polypoidal endometrium for no reason. Again, look at the fluid. The fluid in the fluid is our friend. Fluid in the endometrial cavity helps me delineate the outline of the endometrium very well. You can see there are multiple polyps inside the endometrium. This is on long section, this is on transverse section. You put in Doppler, you will see vessels feeding these polypoidal little polyps over here, like you see over here. There's another one here, can you see? So these vessels keep feeding these little polyps, and this is how it was on 3D, and this was the specimen that we saw after hysterectomy. So you can see these tiny polyps even in the endometrial cavity. So this was complex hyperplasia with atypia. Now sometimes women on tamoxifen may have thickened cystic endometrium, which is sort of a common finding in patients with tamoxifen. But tamoxifen is known to increase the possibility of endometrial polyps, endometrial hyperplasia, and endometrial